Alright guys, now on this video we're going to be talking about dopamine. And so there's one that I think that you absolutely need to pay attention on. This is the guy. We don't use it that often, but when we do use it, I can assure you it is because something really bad is happening. So you've got to be solid in knowing what this drug does, at what doses does what effects, and you got to be able to set it up quick. All right. Now again, I assure you, when you're given dopamine, it ain't because the patient's in sunshine and roses. Okay, this patient's probably circling the drain and is getting ready to die. This is no time to be timid. This is no time to be meek about it. You need to set it, spike it, go. All right. And then you have to know how to work that drug, how to titrate the effects of that drug. All right. And with dopamine, boy, this statement is so very true. No matter how bad you think it is, it can get worse. Now, this is the drug again. Dopamine is also called entropin. You may either see revenamine or dopastat. There are trade names of it, but most of the time, this is the guy you're going to see. Actually, probably most of the time, this is the guy you're going to see is your dopamine bag. It's usually 800 milligrams and 500, or 400 and 250. Kind of depends on the stocking of it. But be careful with that. Let me elaborate just a little bit, because sometimes they can put 400 milligrams in a 500 bag, which changes the concentration. And when we start talking about dosing, that one kind of actually plays a really big point. So what we use this for, we use it to correct cardiogenic shock. All right? And I want to stress that one. Cardiogenic shock is what we like to use. Now, I will tell you that when you get upstairs into the units, you're going to see some different drugs, and we're going to talk about those in later videos. And again, dopamine's got some uglier stepsisters, but the reason that we don't use those other drugs is, number one, they're extremely expensive, and number two, they require special tubing, special refrigeration, blocked from sunlight. So that's why dopamine is probably used more in the pre-hospital setting. But remember, it's used, again, to correct cardiogenic shock. And you got to make sure that the patient's not hypovolemic before you do that. So again, this is a naturally occurring catecholamine within our body. We have this neurotransmitter in our own body. Again, it is the same thing like an epinephrine. It's in the same class, a catecholamine drug. So again, it works both on the speed of the heart, and it works on the force of contraction of the heart, and it depends on what dose you give as to the effects that it does. All right? So again, beta-1 receptors is what it affects. Beta-1, remember, we got one heart, two lungs. All right? But it also has an alpha effect, which affects the blood vessels. That works at higher doses. It goes into a more alpha effect. Okay, so again, dosing matters on this drug. All right. It also, at lower doses, it was thought to believe that, and there's still stocks out there that believe this, that it actually dilates the mesenteric and the renal arteries. So for that, you get better flow of you get a better flow of blood to those at a very low dose of dopamine. Okay, and it's a systolic. It increases both systolic and pulse pressures, and it usually has less effect, by the way, on the diastolic pressure. But the one thing I'll say about that is that systolic's great for getting it out to the body. Remember, diastolic pressure is what we need when the heart is they got a blockage, or you want to cause the anastomes to get more blood in the heart. Again, that collateral circulation. So it doesn't really affect it does affect diastolic, but not as bad as other drugs would do. And an immediate metabolic precursor to norepinephrine. So it will actually, chemically, it's kind of like a half-breed between epinephrine and norepinephrine. I will also tell you this, though, guys. If you give a patient dopamine, it does make them, usually when we have them, we don't get to see it, but it makes them happy. Again, because the dopaminergic receptors in our brain start to get that, and again, it does cause a feeling of euphoria. Now, so again, at 5 to 10 mics per kilo per minute, this is where we hit the beta 1 response, where we get an increase in heart rate. All right, and then you get positive chronotropic and inotropic, chrono meaning time, ino meaning squeeze, okay? So at the low dose to 5 to 10, that's what we get. So from 10 to 20, it's primary and alpha, where it starts to clamp down the blood vessels. Now, if I'm going to clamp down the blood vessels, norepinephrine is usually my guy I go to, okay? But you still get the good effects from the even at 10 to 20, you're still going to get some beta effects as far as output because of the better squeeze and the better fast beating of the heart. Doses after 20 mics per kilo per minute, that's when it acts like norepinephrine. So again, you get actually get a reverse dilation of the renal, the effects of the reverse renal dilation. Back in the old days, by the way, this is where that renal dose, where 2 to 5 mics a minute. These guys, again, they would put them on a low dose of dopamine to try to open up the kidneys in case you had kidney function lowering. And again, there are still some places where that's done. Now, it takes about 2 to 4 minutes for this drug to start working. So despite what you might see in your scenarios when you start your dopamine, usually takes about 2 minutes for the blood pressure and the effects to kick in. And then your duration is about 10 to 15 minutes. So by the way, if you go hog wild and turn up the dopamine too high, and now you're dealing with maybe a rebound tachycardia here, you're going to get 10 to 15 minutes of dealing with the tachycardia. So try to keep that in mind when I say go up slow, okay? So again, it's the drug of choice for cardiogenic shock, especially in the pre-hospital setting, okay? And it's usually, you got to make sure that there's an absence of hypovolemia. So make sure that these patients, usually when I give dopamine, I give about 500 of fluid ahead of time, just to make sure that I've got some fluid in the pipes. Unless I'm seeing huge jugular vein distension, or I've actually got the monitoring equipment to know that the patient's got a good preload back to their heart, I'm going to give them a little bit of fluid before I give them dopamine, okay? Unless I got wet lung sounds, even if I got swollen extremities, I still want to make sure that there's a little bit of fluid in the pipes before I start giving my dopamine. Acute renal failure, we use it, it's not so much now, but they did used to use it. They used that low dose in order to try to open up the kidneys. So again, remember, it's a catecholamine. It's going to cause, if you give it, by the way, too little a dose, again, you can get hypotension. If you crank it up too high, again, you can send their blood pressure through the roof. If you crank it up too high, you're probably going to get a tachycardia. Just remember, if you speed up the heart and you increase the squeeze, that's also going to burn up myocardial oxygen. So if the person's having a heart attack, that might not be the best thing for them to do, okay? Again, get it to squeeze just enough to perfuse the brain till we can get them to the hospital. And if you think that that is a balancing act, you are absolutely correct. It will require your undivided, constant attention, and you got to be precise about it. All right, so again, it can cause some shortness of breath, nausea, vomiting. If this stuff gets outside of the vein, I assure you, you're looking at dead tissue, okay? It's going to start sloughing tissue. So make sure that you've got it in a patent vein. So again, when do we not use it? If they're in cardiac arrest, don't bother. If they're hypovolemic, don't bother. There's other treatments. Phenochromocystoma, it's got a tumor on top of the adrenal gland. If they have uncorrected or under-controlled tachycardia, it's probably not the drug you want to use. Correct the tachycardia first and then go with the dopamine. Idiopathic hypertrophic subaortic stenosis. If they have that in their history, it's a hardening of the aorta, and believe me, you'll probably bust it with the dopamine infusion, okay? So again, if they have high blood pressure, there's no indication to use the dopamine usually, but again, it's kind of a relative contraindication. Remember, it's going to raise blood pressure. Dopamine doesn't like other fluids. I'll tell you that right now. So bicarb, Lasix, calcium chloride, hates it. It's going to precipitate. Again, patients with oxytocin, you could have continued hypertension. So be careful with your pregnant. If you are using this on a pregnant patient, they've got probably a bigger problem going on. Now, your beta blockers can antagonize the effects, so it's going to work against it. So you might need a little bit more dose if this patient's normally on a beta blocker regimen. Tricyclic antibiotics and MAOIs, these guys, they potentiate the effects. So if they're on psych drugs, it probably is not going to take much dopamine to get these guys going. Using dopamine with Dilantin, which is the phenytoin, you can actually get blood pressure problems, bradycardic problems, and then again seizures. And any of your sympathomimetics or phosphodiesterase inhibitors will exacerbate the dysrhythmia response. In other words, if they're on the little blue pill, they're going to probably throw a lot more PVCs with it. Something to keep thought about. So again, need a large, stable vein to infuse this through, okay? Matter of fact, if you got it running through a tiny vein, it might be a good idea to get a bigger one started. And you can use this through the IO, by the way. Again, phenochromocitosis is a benign catecholamine. So the product, it produces epinephrine, essentially. So it can cause hypertension in the patient. You give them a little bit of dopamine through the roof. Okay. And I'll tell you the only reason we know this was we used to have a paramedic who thought he was a God's gift to paramedic, and the doctor decided to give him the famous ACLS code of the patient with who had phenochromocystoma, and of course the second he started a dopamine drip, boom, threw his blood pressure through the roof, that he didn't know what to do, and it kind of humbled him out just a little bit. Again, discontinue gradually. If you're probably not going to ever be in a position to take them off of it. But if you are in that situation, slow is the way to go. We don't want to stop it immediately, unless, of course, they go into like a cardiac arrest. If they go into cardiac arrest, guys, shut it off. When you get them back and you need it back on, then turn it back on and work up, okay? Again, tissue necrosis if it gets outside the vein, so be careful with that. And again, your MAOIs, all of those lovely drugs there, again, it's going to require a reduced dose. If you have any of those drugs there that they were talking about. How it's prepared, and this is the one that, and we're going to talk about the cheat method real quick in just a moment here. But the biggest thing is you got to know, and most of the time, and this is the big one right here, is it's pre-mixed 1,600 mics per ml. That's your big one, okay? That, and especially if you're using the cheat method, which I'm about to teach you, which I don't recommend doing for any test, but when you need a calc in a hurry, it actually works pretty good, okay? So 1,600 mics per milliliter is usually the pre-mix version. A lot of places have the 400 milligram vial that I showed you guys earlier, and then what you're going to do is push that into a 250 bag. That gives you 1,600 mics per ml, okay? Now, yeah, dopamine, there you go. So again, 400 and 250 gives you 1,600 mics, 2 to 20 mics per kilo per minute, okay? Rarely ever do you go over 20 mics per kilo per minute in the field, okay? So very, very rarely will you be doing that, all right? So again, dopaminergic effects, where we just get the better conduction, a little bit better squeeze, renal dilation, 1 to 5 mics. Beta effects is 5 to 10. And by the way, we usually start this drug at 5 mics per kilo per minute, okay? And then alpha is 10 to 20, okay? Again, you should never, ever exceed 50 mics per kilo per minute, okay? Very rarely do we do that, and we usually do that only if the doctor is saying to do so. And there are some dumb occasions when, yes, you will need to do that, okay? Your pediatric doses. Guys, I can tell you right now that dopamine is usually not used in the pediatric patient. We usually go straight to epinephrine, okay? But for the dumb time that you might actually use dopamine, you're going to mix 200 in 250, which gives us a smaller concentration, okay? And the smaller concentration is easier to titrate, because usually with a pediatric patient that weighs maybe 40 to 50 pounds, we're going to be starting this literally at 5 drops a minute on a 60 drop set. So the smaller concentration is a lot better and easier for us to control the drips, okay? By the way, if you are giving it via the pediatric dose, you're going to be using the long method. You don't ever use the cheat method. You always find out exacts on that one. So backing this up real quick, again, like I said, most of the time we use this on our epi drips on pediatrics. So if you're hanging a dopamine drip on a kid, you're probably using the wrong drug. It's probably better to go for your epinephrine drip, and the epinephrine drip's a little easier to do. Now, the one thing I'm going to teach you about dopamine, and hopefully you already know it because you've learned it in lab already, but if you haven't learned it, and I call it the cheat method. Now, if we use the cheat method, a couple things we absolutely got to make sure of. Thing number one that we absolutely got to make sure of is that your 1600 mics per ml, okay? Got to make sure that that's your concentration. Otherwise, the cheat method, what I'm about to show you, you got to adjust it. But again, for my purposes, it doesn't work, okay? What I usually do is take the patient's weight in pounds, okay? And I noticed that I said pounds, all right? What I do for the cheat method is I drop whatever the last number is, okay? Now, depending on the size of the patient is how many I minus. So if it's a small patient, I minus 1 drop. A medium patient, I minus 2 drops. A large patient, I minus 3. Now you say, well, what's the exact numbers there? And actually, truth be known, I use the 30-20-10 method there. So if I'm at 10 drops or less, then I minus 1. If I'm between 10 and 20, I minus 2. Between 20 and 30, I minus 3. Now, if I do out the math on this, okay, if I actually do the long method of determining a drug calculation, you're going to find out that this is pretty close. So in this particular patient here, I've got a big patient. I'm going to minus 3, and that gives me 27. So I would start at 27 drops a minute. This is a 60 drop set. So a couple rules with this. Rule number one is you got to have 1600 mics, okay? Rule number two is it's got to be on a 60 drop set, okay? And then number 3, don't forget the minus, okay? So again, take the weight in pounds, drop the last number, and then depending on the size of the patient, minus 1, minus 2, minus 3, okay? And again, if I was to do the math out on this, you would find out that it's not maybe 1 drop off, maybe. But when you're doing a quick calculation. Now, the third part of this little thing is what does this give you? This is your starting dose. This is 5 micrograms per kilo per minute. Well, what happens if I need more? Then you turn it up. But usually only turn it up maybe 5 drops and let it keep going. All right, depending on how big the patient is. Again, if I've got a really teeny tiny person, I'm going to flip over to here. If I've got a teeny tiny person, by the way, notice, by the way, that that's not going to work if we're going to use a pediatric patient, right? There's a lot of math going on there. So again, epi drips are a lot easier to use on the kids. Going back to this guy right here, erase all the ink on the slide there. So if I've got, let's say, I've got a 140-pound patient, okay, I delete the last number, right? So 14 minus 1, actually minus 2 there because they are a medium patient, right? So I'd start my drops at 12 drops a minute, okay? It's that simple to use what's called the street method on this. But I will tell you that the street method is not exact, okay? So again, the street method gives me 5 mics per kilo per minute. Now, I know it went a little long on this one, and it's probably again, you know that. By the way, we only give this via IV infusion. IO infusion is actually okay to do too. So, again, and you can use it on your pregnant patients, but I can tell you if you got that big of a problem, something else is probably going on. I don't think in all the years I've ever done this, I've ever had to give dopamine to a pregnant patient. So, hopefully you will never have to do that. So, like I said, guys, dopamine is you gotta know it, all right? And don't just, I think it's this. No, because you got to make sure, and probably when you get back to the station, speaking of that, when we get back to the upper limits here, so if I know what the upper limit for my girl here, so that's 5 mics per kilos. I don't want to go any more than 20 mics per kilo. So the limit on my patient here is going to be, that's 5 mics. I know that this is going to be 10 mics. And then if I double that one, I know that that's going to be 20 mics. So if I'm getting up to 48 drops a minute, which is just a little bit faster than 1 drop a second, or just a little bit slower than 1 drop a second, or pretty much 5 drops every 4 seconds, I know that, 4 drops every 5 seconds. I know that if I do that, I basically know what my upper limit is for my dopamine drip, okay? And by the way, if I do have the choice, it very rarely happens, but if you do have a pump, the pump is the way to go, right? Remember, 60 drop sets, they're wonderful, they're great, but they're not exact, all right? When you're in a hurry, they're great. But exact is what you probably need, all right? So again, how I calculate the upper limit here. Again, whatever my 5 mic per kilogram dose is, if I double it, that would be 10, right? Change ink colors here. Ink color, let's go to the red. So I know that this is 5 mics per kilogram per minute. I knew in this case it was 10 mics per kilo per minute. I know that that's 20. So if I'm getting above that, I don't want to give them any more. And this is, again, for our patient who weighs 140 pounds. All right? All right, I hope that was clear as mud. Again, this is one you're probably going to have to study a couple times, all right? And you need to, because, again, when you're given this drug, it can save their life. Again, too much can kill the patient. I'll talk to you guys on the next one, and good luck with the dopamine stuff.